Yes. Okay, I will share my slides. So, good morning, everyone. Now we will have the sixth webinar of fetal maternal medicine, organized by the Fetal Medicine Unit of the University of Chile Hospital. And today, as you can see on the poster, we will have a leader of the fetal medicine worldwide, which is who is Professor Kypros Nicolaides. And Professor Kypros Nicolaides has more than 1,300 publications from 1982 to date, about 40 of them in the most relevant medical journals, such as The Lancet and New England Journal of Medicine. The impact of his publication in the public policy has very important role in our days. And for that, I would like to sort of remark some of them. First of all, those about preterm delivery. Chile has a health system that guarantees certain pathologies, including premature deliveries. The clinical guidelines for preterm birth was updated recently in 2017, and it explicitly points out three aspects that come from Professor Nicolaides' research. First of all, the usefulness of cervical measurements. Second, the usefulness of the use of progesterone in prevention of preterm birth. And third, the prevention of preeclampsia using aspirin. Second, we have now an abortion law, and Chile approved as well recently in 2017 a law that regulates the voluntary interruption of pregnancy in three causes. First cause is the risk of maternal life. Second, the lethal malformation. And third, pregnancy resulting from rapes. For cause 2 of this law, all the research by Professor Nicolaides on screening for aneuploidy and congenital malformation in the first trimester of pregnancy are essential to allow equal access to these women, to this law. And thirdly, I would like to as well talk about the access of fetal therapy. In 2005, we began to implement in two hospitals, one university and the other public hospital, a laser therapy in monochorionic twin pregnancy with twin-to-twin transfusion syndrome. The support and research of Professor Nicolaides has been essential for this success in this initiative. Therefore, listening to the talk update of the pyramid of care is essential for us to understand how to improve the health of pregnant women and their fetuses, of course, in Latin America and around the world. So, Professor Nicolaides, now we listen to you.
So, what do this now? Try to.
It's on the left, Prof.
Yeah.
Okay. Excellent.
Dear Mauro, Professor Para, thank you very much for your introduction. All I need to say, of course, is that the unit at King's College Hospital that I headed from 1984 was at the beginning of this new field of fetal medicine, and a lot of people, many of them that are in the panel today, came and received training and participated in the research that was carried out over the last few decades. So all of these contributions that I'm very glad to hear have helped improve healthcare in Chile are not because of me, it's because of the many collaborators and many of the research fellows that participated in this work. Now, this inversion of the pyramid of pregnancy care, which would be the topic of my talk today, arises from this man. In 1900, this gentleman, George Ballantyne, a great obstetrician in Scotland, wrote an article in the British Medical Journal because he realized that despite all the efforts, the maternal and perinatal mortality remained extremely high. The rate of maternal death at that time in England, 1900, was the same as it is today in Southeast Asia, in India, Bangladesh, Pakistan. And what he recognized, Ballantyne, was that at the time, the only care that was available was for very wealthy women, and that care was confined to the time of birth. So Ballantyne recognized that a lot of the causes of death and handicap were preceding the onset of labor. And in this article, he suggested two things. Number one, that we should introduce prenatal, not just intrapartum care, and that this prenatal care should be available to the whole population, not the extremely few wealthy ones. Of course, he recognized that these two proposals were very revolutionary for the time, and he recognized that there would be a lot of difficulties in the way, and many of his colleagues and others would regard them as visionary or highly unrealistic. Quite often in my own career, if somebody wanted to be nasty, in a very nice way, they would say, yes, this is very, very good, but it is only good in your hands. It's completely unrealistic. So it was a sort of a compliment, which meant it was an insult. And he recognized that. And that is what happened in 1900. He campaigned for this and nobody listened. Well, certainly none of the medical profession listened. There was, however, something very interesting happening at that time. And there was a group of the population, not of the profession, the population that listened to him. This was a group of terrorists, middle-class women that were demanding the vote. But they were demanding the vote in a very revolutionary type of way. They were throwing bombs, they were jumping on the police, they were chaining themselves in the House of Parliament, they were throwing themselves in front of the horse of the king and they were getting killed. They were being arrested by the police and they were put in the English Guantanamo Bay, where they were tortured like the Americans are torturing the prisoners there. They were force-fed with tubes, and then they were going on hunger strike. Again, they were arrested and they were being force-fed. These women were demanding the vote, but actually, they also recognized that having the vote on its own was not useful unless it was accompanied by major social reform. And therefore, they took on the slogan and they campaigned for the advocacies of Ballantyne, and they demanded the vote, but they also demanded that there should be universal prenatal care. Eventually, the suffragettes succeeded, and in 1928, they received the vote. And in the first elections, after that vote, the Liberals won the government in England. And one of the first actions of the Liberal government, with this very sexy looking Arthur Greenwood, a lawyer, was to introduce this document on maternal mortality in childbirth and the introduction of prenatal care. This was in 1929. And this very nice looking lawyer suggested that women should be seen at 16 weeks and then at 24 and 28 every 4 weeks until 28 weeks, and then every 2 weeks until 36, and then every week until delivery. Does that sound familiar? Is that what happens in America and in Afghanistan today? Yes, and in Chile, of course. And that is certainly what happens in England. Women are seen not very much in the beginning. Then they are seen every 4 weeks until 28, every 2 weeks until 36, and then every 1 week until delivery. So carry on doing that. But remember, what is the scientific basis of it? It was the delusion, the invention of a lawyer, Minister of Health in England in 1929. Well, the lawyer was not too stupid. He realized that there wasn't anything very much that anybody could do in the beginning of the pregnancy. We did not have ultrasound at that time. You could not properly assess the pregnancy. A lot of the complications, the majority, were happening at the end. And therefore, he proposed a pyramid that was very heavy at the bottom. See the women at the end. But the ideology of that pyramid was that a lot of complications happen at the end, so women should be seen a lot at the end so that we diagnose these complications and then hopefully do something to prevent the women from getting worse. It was not a preventative pyramid, it was a reactive pyramid. Well, it is extraordinary that 100 years later, in most countries of the world, we are following exactly the same pyramid as if nothing has happened in the last 100 years. But in my mind, something happened in 1992. And this is from the publication in 1992 in the British Medical Journal, when we described that in pregnancies with Downs and other chromosomal abnormalities, there was a big black space behind the neck of the fetus that was visible in the 12th week of pregnancy, by comparison with a smaller black space in chromosomally normal babies. That created an opening, a new way of looking at things. We could diagnose chromosomal abnormalities in the beginning of the pregnancy. Very soon after that, we were beginning to diagnose major fetal abnormalities. Very soon after that, we realized that we could combine the information from ultrasound, the nuchal translucency, with various biochemical markers, Bifida, HCG, and PABA, to be more accurate in our prediction of Downs and trisomies, other trisomies. But we also realized that if the ultrasound was showing increased nuchal and the baby did not have a chromosomal abnormality, it could have a major heart defect and any one of more than 100 different genetic syndromes. We also realized that if the maternal serum PABA was low and the babies were chromosomally normal, a lot of those pregnancies, depending on how low the PABA was, would end up with an increased risk of miscarriage, of stillbirth, of fetal growth restriction, of women developing preeclampsia and abruptions. So suddenly, a 12-week realization of an association between increased nuchal translucency and chromosomal abnormalities was beginning to introduce many elements of thinking around many other pregnancy complications. So it was the beginning in my mind of this concept of the inversion of the pyramid of care. And this is represented here, really. My vision was that women should be seen properly at 12 weeks, not at 16, and that this first assessment will become the most important one in pregnancy care, because the rationale of this assessment was twofold. First of all, to define a mathematical model for each pregnancy complication. In many respects, obstetrics until that time was a hostage of these delusions of grandeur of obstetricians that they are Leonardo da Vinci's. They kept proudly referring to obstetrics as the art of obstetrics. Good obstetricians are great artists. Delusion. To me, my hero is not the Leonardo da Vinci, the artist, but the Leonardo da Vinci, the scientist. And the real the real basis of science is to convert an observation into a mathematical model. So I was hoping that we will develop mathematical models and that in the beginning of the pregnancy, each woman will have a risk for all of the major pregnancy complications. And that risk, rather than an artistic delusion, would be stratifying the subsequent level of pregnancy care. I also believed that with this model in mind, in years to come, when for sure I am not alive, many researchers, molecular biology, mathematicians, bioinformaticians will be developing more and more understanding and models for the prediction of pregnancy complications, where more information will be integrated in this first pregnancy visit. However good, this first pregnancy visit is, it is very unlikely that it will be complete in the prediction of all pregnancy complications. I think that women should also be seen again at around 20 weeks. I put here 22, because many of those that were considered to be at very high risk in the beginning will now prove through the course of the pregnancy not to be at such high risk. And others that in the beginning we thought were at low risk will now be reclassified as being at high risk. And then a final assessment at 36 weeks, which I call the birth plan assessment. In many advanced European countries, at least, there is a third trimester ultrasound scan that by accident, it was placed at 32 weeks. Like many things that we do, we just impulsively introduce certain clinical measures. This impulsive behavior of introducing a 32-week scan created a stupidity in classifications of disease. And we see in subsequent years, purely because we scan women at 32 weeks, the creation of this arbitrary definition of early and late preeclampsia, early and late IUGR, completely meaningless, as if something dramatic happens at 9 o'clock in the morning of your 32nd week that converts one pathology into another, the early and the late. Well, nothing like that has happened. It was a historical accident that women were having a 32-week scan. And that is what led to these definitions of the early and the late that enter into silly guidelines by ISWOC and whatever you call them, DEFI, consensus opinions by self-deluded experts, and so on. But it is silly. In reality, when you do introduce a 32-week scan, routinely, you recognize very, very quickly that many of the elements for the introduction of a 32-week scan are not valid. At 32 weeks, we will diagnose major fetal abnormalities. But of course, at 36 weeks is when it is much more likely that some of the most severe types of late onset microcephalus, hydrocephalus, some fetal cardiac defects that you missed previously will be declaring themselves. At 32 weeks, you will be diagnosing a malpresentation. But it is absurd to think that if you diagnose breech at 32 weeks, it's of any clinical value whatsoever. And yet, if you were to diagnose breech at 36 weeks, there's a very clear clinical pathway is what you do. You bring them in a week later, and if you want, you attempt external cephalic version, and if you fail, you book them in for an elective cesarean section at 38 weeks. It is absurd to think that at 32 weeks, we can predict fetal growth restriction at term. We have done that, and we miss the vast majority. More than 60% of the small for gestational age neonates will be missed by your 32-week scan, whereas if you bring the scan closer to the birth, for the vast majority of the cases, you will be more successful in diagnosing, for example, fetal growth restriction that you missed before. So to me, a scan in the third trimester is a scan that should be done so that at the end of the pregnancy, we reassess all of the information that we have and we decide whether we deliver early or late, whether we deliver by cesarean section or vaginally. I will be talking later in my lecture about, for example, preeclampsia, how a lot of our efforts were in the prediction and prevention of preterm preeclampsia with hardly any impact on term preeclampsia. And yet, term preeclampsia is 3 to 4 times higher than preterm preeclampsia, and although individually is less severe, in reality, the contribution of term preeclampsia is equally important or more so overall than preterm preeclampsia. And if we were to be assessing women for their risk of subsequent development of preeclampsia, impaired placentation that will not allow them to withstand the stress of labor, this is the stage of pregnancy at which we would be seeing them to be defining the best time of induction of labor or elective cesarean section. So this is the logic that was proposed. It is not solid by definition. I'm the descendant of Socrates, who recognizes that nothing is definite and everything is in a flux state of evolution, that things will change. The shape of the pyramid will change by the ideology of early prediction and prevention and mathematic incorporation into the previously thought of art of obstetrics should be the basis of prenatal care. And then let me give a few examples where this has worked and others where it has not. Early diagnosis of trisomies is simple, really. In the 70s, we had a method based on maternal age that would identify about 30% of the babies with chromosomal abnormalities at a false positive rate of 5%. In the 80s, we moved to a second trimester. The pyramid of 1929, the magic that prenatal care believes at the magic defined in 1929, the 16-week logic, where people recognize that at that 16-week assessment, you can combine information from maternal age and various biochemical markers in the mother's blood to identify about 70% of the babies with Downs, and then the shift into the first trimester in the 90s with a combination of nuchal translucency, free beta HCG, and PABA that was now increasing the detection to about 90% for a false positive rate of 5 again. And of course, we have in the year 2000 and beyond the description of additional ultrasound markers, absent nasal bone, abnormal flow in the ductus venosus, reverse flow in the across the tricuspid valve that remain confined, unfortunately, to a few specific supercenters. It was impossible for this to be introduced widely. And the British government, for example, when eventually they were forced to adopt the first trimester combined test, became fanatically against us, even at King's, doing the additional markers because they could not be done throughout the country. And I leave it at that. And then another big leap forward in the 2010, in reality, when the first description of Dennis' law from the 1997 on the realization that when the cells of our body die, they release fragments of the broken down nucleus. The DNA within the nucleus is released outside the cells into the surrounding plasma. And then it takes about 15 years before the appropriate technology makes it possible to identify the origins of these DNA fragments in the mother's blood and the creation of a cell-free DNA test. And we were there from the beginning. I collaborated with almost all of the cell-free DNA companies because I could see that this was the future, and therefore I did not need to defend my method of the past. We have to have an evolution whereby the new method could be introduced into clinical practice. And we carried out a series of studies involving cell-free DNA testing with many of the companies. And this is the result from a meta-analysis that we carried out in 2017, where in nearly 2,000 cases of Downs and about 500 cases of trisomy 18 and less number of trisomy 13, it was obvious that the performance of screening was far superior to what we had before, with detection rates for Downs of more than 99% and false positive rates of less than 0.1%. So this is very clearly much more advanced than anything we had before. However, at the same time, there were two challenges. The first one was that the cost of the test was extremely high. I campaigned and I convinced some of the companies. When it was first introduced, the test was about $2,000. I then tried to negotiate with various companies. I succeeded with the Ariosa company, now with Roche, the Harmony test, to do it for £400 and now for 200 pounds. But there are new technologies coming about, new tests being introduced where the cost will be less than $100. And I believe that soon, within the next 3 to 5 years, the cost will be in the region of $40 to $50. There's no reason why it should be any higher than that. And that, of course, will make it much more applicable to a wider spectrum of the population. The second element that was very, very important for me was to emphasize that this was a test for Downs and a few other trisomies. It was not a replacement of the first trimester scan and what else we had gained in the previous decades from the first trimester assessment. And the model, therefore, that I was proposing is that we should continue with the first trimester scan and then define the subgroup that would most benefit from cell-free DNA testing stratified on the basis of the results from the first trimester combined test. There would be a very, very small group of women with an extremely high risk where we should not investigate them by doing a cell-free DNA test because that is silly. In this group, we have Downs and many other chromosomal abnormalities, and the best management is to do an invasive test. We have a low-risk group where we should not be wasting certainly public health money for this group because the yield is going to be very low and there are so many other things that can be done in medicine. And the best candidate for cell-free DNA testing was the group with an intermediate risk. And then the question was, how do you define this risk? And the answer is, how much money do you have? Nothing medical about it whatsoever. How much money do you have and what is the cost of the test? In England, because it's a very poor country, they can only afford to offer the cell-free DNA test to 4% of the population. And therefore, they have declared that we can do cell-free DNA testing only in the 4% of the population where the risk from the first trimester combined test is 1 in 100. In other countries, like Switzerland, France, Germany, they have drawn the line at 1 in 1,000. All you need to recognize is that it very much depends on what is the cost and what is your objective. If in England, all we need to do is spend money for 4% of the population, then the overall detection of Downs would be 88%. If we really want to move up and detect nearly all, let's say 98%, the cutoff must be about 1 in 2,000, in which case we should be offering the cell-free DNA test to about 20% of the population. These percentages, these risk cutoffs will be shifting year by year, depending on what is the cost of the test. What we should not do cell-free DNA testing for is if we find a very high NUCA of 3.5 or more, if we find holoprosencephaly, megacystis, or things like exomphalos. Overall, the incidence of these, let's say, 4 features is about 1%, and these are not investigated by cell-free DNA testing. These must be investigated by CVS and array CGH, because here we want to diagnose as many chromosomal abnormalities as possible that these conditions are associated with. Let me now move into the issue of early diagnosis of fetal defects. And let me just go back a few decades to the 1970s, when this nice-looking man on the right used to be young Professor Stuart Campbell, my teacher. And these were the type of machines that we had in the late 70s, even early 80s. And he was the only one that could see things. Nobody else could see that this baby was anencephalic and this baby had spina bifida. So much so that in the 1970s, the method of screening, late 1970s, mid 1980s, the method of screening for spina bifida was not ultrasound, was not based on fetal medicine, it was based on biochemical testing. It was maternal serum alpha fetoprotein at 16 weeks. And it's as simple as that. Until entirely by accident, in 1986, we described that in the 16th week of pregnancy, the shape of the head is lemony and the shape of the cerebellum is banana-y in cases of babies with Down, with spina bifida. It took at least 10 years of a battle for this method to be adopted in England. And in the United States of America, it was only 3 years ago that the colleges acknowledged that we don't need to do alpha fetoprotein, we can screen on the basis of ultrasound. 3 years ago. That is 40 years late. In the meantime, we, together with Rabbit Chawi, we found that in the first trimester, the signs of spina bifida were a change in the shape of the posterior fossa. Instead of having 2 lines, we only had 1 line, because as the brain was pulled down by the leaking cerebrospinal fluid, as the midbrain was pulled down, the brainstem was getting fatter at the expense of the cisterna magna. And therefore, we see here the evolution in terms of screening for one example of fetal abnormalities. In a recent study, we examined more than 100,000 pregnancies in the first trimester systematically, and then we decided to classify the various defects according to their detectability. Acrania and holoprosencephaly should always be detected. body stock anomaly, major cardiac abnormalities, exomphalos and gastroschisis. Mostly detectable are the ones that depend on how much you want to look for them. For example, spina bifida, if we spend time looking for the posterior fossa and then examining transvaginally, for example, systematically the spine, you will be diagnosing them all. But let's say the majority. And then things like hypoplastic left heart and lower urinary tract obstruction by the identification of megacystis. When you see megacystis, many of them will resolve without any problems. Others will evolve into obstructive uropathy. But some of the obstructive uropathies that you will diagnose in the second trimester will have looked normal in the first trimester. And then you have others that are occasionally detectable and others that are never detectable. You can never detect in the first trimester a ventriculomegaly as a consequence of a brain hemorrhage at 22 weeks. You will not be able to diagnose in the first trimester absent corpus callosum, septo-optic dysplasia. These are diagnoses that become apparent only after 17 weeks. You cannot diagnose cystic adenoidal malformation of the lungs because the fluid accumulation within the obstructed lung will only become apparent after 16 weeks, and therefore the echogenic lungs will become apparent only at that stage. You cannot diagnose bowel atresias, even if they are present at 12 weeks, because the way we see them is by the fetus swallowing fluid that is not absorbed, and therefore the bowel is distended, and this is a diagnosis in the not even at 20 weeks. We can diagnose them after 24, 26 weeks when these women present with polyhydramnios. Hydronephrosis, retrograde flow, vesico ureteric reflux is usually something that happens in the late second trimester, third trimester. And that is why I think that some of these abnormalities will only be detected in a 36-week scan. Things like ovarian cyst. I have never seen an ovarian cyst at the 20-week scan. These are always third trimester diagnoses. So this scheme is showing the inversion of the pyramid of care, what it can achieve in terms of fetal defects in the first trimester, but actually also the necessity to continue with a 20-week scan and actually even look for fetal abnormalities at the 36-week scan. And then early prediction of preeclampsia. And I go to what is established in England and in the United States and in every village in Pakistan, a history-based approach to the prediction of the pregnancies at risk. We are in preeclampsia where we were in screening for Downs in the early 1970s, asking women 10 questions. And if they say, yes, I had a previous preeclampsia, chronic renal disease, chronic hypertension, diabetes, or lupus, then you are classified as being at high risk. Then we ask another 5 questions. Is this your first pregnancy? How old are you? How obese you are? What is the interval between this and your previous pregnancy? And do you have a family history of preeclampsia? And in the United States, are you poor or black or both? And then if you are positive for 2 out of these 5 or 6 additional factors, you're also classified as being at high risk. What a primitive way of thinking in the era of a lip service to the concept of personalized medicine. Personalized medicine means you are told what is your personal risk, 1 in 2 or 1 in 1,000. You're not told you are high risk or no risk. Yes, it is very simple, but it is not good. Asking people what is their age is very simple, but it was not good as a method of screening for Downs. Asking people 10 questions is simple, but it is not good in the prediction of preeclampsia. The battle for the adoption of the new methods will last for decades to come, unfortunately. It has taken us 30, 40 years to arrive at this one slide. The first trimester prediction of preeclampsia based on a combination of maternal factors put together through a multiple regression model with the addition of uterine artery pulsability index, mean arterial pressure, and maternal serum placental growth factor that at the 12th week of pregnancy will identify about 90% of the women that will develop preeclampsia before 32 weeks, 75 of preeclampsia before 37, and not too much, about 40 to 45 of preeclampsia at term. A series of validation studies to confirm the original suspicion that this was the way forward, and followed by a multi-center study where we screen by this method. We identify the high-risk group. We give them 150 milligrams of aspirin from 12 to 36 weeks in pregnancy, and we reduce the rate of very severe early preeclampsia before 32 weeks by 90%, preeclampsia before 34 weeks by 80%, preeclampsia before 37 weeks by 60%, and no real impact on term preeclampsia. We also learn that the biggest cost of obstetric care actually is neonatal intensive care, and most of the cost is in neonatal care admission, especially for babies born before 32 weeks. And because we are dramatically reducing the rate of very early preeclampsia before 32 weeks, we are also reducing the length of stay in the neonatal intensive care unit. And this alone is more than enough to pay for the cost of universal screening of the whole population. But of course, again, the story is only half done by screening and prevention in the first trimester. Still, if we predict 75% of preterm and we prevent 60% of those, it still means that many preterm preeclampsias will not be predicted or prevented. And in the first trimester, if we predict only 45% of the term preeclampsias, which are the majority, and we cannot do anything to them, still we have a lot of term preeclampsias. So it is necessary to investigate additional markers for the different stages in pregnancy. And this slide summarizes a lot of work over the last few decades. Mean arterial pressure is useful across the trimester. Uterine artery Doppler is not useful at term. Placental growth factor is useful across. FLIT is useful in the prediction of preeclampsia within the subsequent 3 to 5 weeks. Therefore, it is useless in the first trimester. And PABE is useful in the first trimester if you don't use PLGF, but it is not useful thereafter. And as I said, it has taken us several decades to produce this slide. More recently, inspired by work that was carried out in Brazil and through a Brazilian research fellow, as I mentioned before, it is the effort of many. It's Mauro, it's Gerard, it's Hernandez, it's many people that have been as fellows that have brought ideas and improved care. We started looking at the ophthalmic artery. Just to remind people, the ophthalmic artery is the first branch of the internal carotid artery, and therefore it is an easily accessible vessel to give us information about cerebral perfusion. And you can put a linear probe, 7 to 15 megahertz on the upper eyelid for a few seconds. Then you follow the traditional rules of Doppler assessment, and behind the eye you see the ophthalmic artery, and you get this double systole and diastole, the first and the second systolic wave. And just to remind people, the second systolic wave is a reflective wave. So when you find increased velocity, that does not mean that you have increased flow, but it means the opposite. It means that you have increased peripheral resistance. The more the peripheral resistance, the higher the peak systolic velocity of the reflective second wave. And we found through 2 major studies at 20 and 36 weeks that this second divided by the first systolic peak systolic velocity is predictive for the subsequent development of preeclampsia. And the closer you are to the event, like everything, uterine, MAP, PLGF, FLEET, the greater is the deviation from normal, the blue line, in those that develop preeclampsia. So these are in terms of the markers. I believe that we should be reassessing the risk at 20 weeks. And this again, just to illustrate the ideology more than the specifics. I mean, you have now carried out studies involving all the biomarkers at 20 weeks in about 50,000 pregnancies. And on the basis of that, we are beginning to stratify, based on the risk, the subsequent care. A very, very small group that you must see regularly. See regularly means ask a midwife to check their blood pressure every week, and ask the women to put a dipstick in their urine to check for protein. A very high risk group that is at risk of developing preeclampsia before 32 weeks. Then an intermediate risk group of about 10% of the total that are at risk of developing preeclampsia between 32 and 36 weeks that we reassess at 32 weeks. And then a low risk group, about 90% of the population that are seen at 36 weeks, because that is the best time to check for term preeclampsia. And to confirm that, this is the prediction of preeclampsia at term at different stages in pregnancy. We pick up about 45% at 12 weeks and at 22 weeks, a bit more at 32 weeks. And you're only beginning to hit the 75% detection rate when we screen by a combination of history, mean arterial pressure, placental growth factor, and FLEET, not uterine, at 36 weeks. And then we carried out a major study based on the results of that, of randomizing women into pravastatin or placebo. We will be publishing the results soon, but the only thing I can tell you now is that they were disappointing. I believe that the way forward is to stratify based on the risk, the women, into those that should be having induction of labor at 37 weeks, a very small group of 1 to 2% of the population, another 5 to 10% that should be induced at around 38 weeks, and then the rest can deliver whenever they feel like it or based on other reasons. But this is again to illustrate the ideology of how we start in the first trimester with the new pyramid, how we incorporate the second trimester assessment, and how we have a third trimester, 36 weeks assessment for different reasons at different stages. Similar sort of ideas are being proposed for the prediction of small for gestational age. But you know, I mentioned before this silly arbitrary definition of early and late IGR around 32 weeks. It's very silly, really. The problems with having small babies are a function of 2 factors, not around specific steps, but in a continuum. At 34 weeks, it is worse than at 35, and at 35, it is worse than at 36, and at 32 is worse than 33, but nothing magical happens on the morning of the 32nd week. The risk is a continuous risk. With decreasing gestation, the risk is greater, and with decreasing size. So we are developing models. It's a Greek research fellow now, Yannis Papastefanou, very good in mathematics, where he's developing 3-dimensional models to take into account both the gestational age and the birth weight Z-score. And I expect that, again, based on these models, we will be stratifying the subsequent monitoring of the pregnancies in a mathematical way. Let me now move to spontaneous preterm birth, because this is, in many respects, the leading cause of death and handicap in obstetrics. I will spend a little bit of time on that, although I'll try and go faster because I have a lot of more slides to show. The rate of preterm birth is about 6% before 37 weeks, but the preterm birth that really matters is birth before 32, 33, 34 weeks. And some of them, about 40% of these preterm births before 34 weeks are iatrogenic, mainly for preeclampsia and fetal growth restriction, and the others are spontaneous. Well, the iatrogenic preterm births, to a great extent, can be prevented, the 40% of them, by first trimester screening and administration for preeclampsia and growth restriction and administration of aspirin. What about the spontaneous preterm birth? Well, the last 50 years, all sorts of weird things have happened. Bed rest doesn't help. All sorts of vitamins and irons and psychological support and all the rest of these psychobubbles, I call them, they don't work. The question is 17-hydroxyprogesterone in women that had a previous preterm birth. This data, that original study from mice that showed that there's a dramatic reduction in the rate of preterm birth. An American company receiving, as a result of that, the permission from the FDA to market 17-hydroxyprogesterone, and they commit a crime against humanity by increasing their price from $200 to $12,000. I mean, this is criminal activity as far as I am concerned, because the very most vulnerable groups, the poor groups, especially in the United States, where there is inadequate health care, that are at the greatest risk for preterm birth, are being deprived of the potential benefits of prevention. Well, the only thing that the FDA asked this company to do is to repeat the study, and they did, and it showed that it is not useful at all. So in terms of prevention of preterm birth, asking women whether they had a previous preterm birth and giving them prophylactic progesterone, that does not work. The only thing that works is in women that are at high risk of preterm birth, because they have a short cervix, cervical cerclage is useful if, in addition to the short cervix, they had a previous history of preterm birth or a previous history of late miscarriage. If the cervix is short and they did not have such a history, the rate of preterm birth is not reduced by cerclage. What about the cervical pessary? We have two types of studies here. One from the Goya group in Barcelona that showed a dramatic improvement in the rate of preterm birth, and our study that showed no impact at all. And the recent meta-analysis by the group of Romero, in which I was also included, which showed that the pessary in women with a singleton pregnancy and the short cervix overall does not reduce the rate of preterm birth. So the only things that we have really is that in women that have a high risk for preeclampsia, preterm birth can be preventable, the iatrogenic preterm birth. For the rest of the population, you need to have a routine second trimester ultrasound scan and the measurement of cervical length. And if this is short, you treat them with progesterone. And if it is short and you also, in addition to that, have a previous history of preterm birth, then cervical cerclage. And both of these interventions will reduce the risk by about 40%. What about twins? Well, there is a disaster, because if the rate of preterm birth before 34 weeks is about 1.7% in singletons, it's 10 times higher in dichorionic twins, and it is 15 times higher in monochorionic twins. And unfortunately, although this group of the 2% of the population that have an extremely high risk for preterm birth, there is nothing very much that could be done to prevent it. If anything, bed rest has a tendency to increase neonatal death and the tendency to increase premature birth. The same with cerclage for a short cervix in twins, a tendency for an increase in the rate. What about the pessary, the Arab pessary? No impact whatsoever. A study from the Netherlands and by our group in England and essentially Spain showed no impact, except there is some evidence from some of the studies, again, from Holland and from Barcelona, that in women with a short cervix, there may be a benefit. We found that not to be the case. Bergela did a study in the United States. It was not beneficial. And Jane Norman did a major study in England with massive numbers of patients, and it was not useful. So Roberto Romero again did a recent meta-analysis that was published in the American Journal that showed that in unselected twins, in twins with a short cervix below 25 or 38, there is no significant reduction in the rate of preterm birth by the insertion of a vaginal pessary. Progesterone in unselected twins is not useful. And the question is whether this is too late, because most of these studies were done in the second trimester, and the dose of progesterone that was used was the same as in singleton pregnancies. To answer the question whether by giving a higher dose, 600 milligrams every day, and starting early from 12 weeks, we conducted a major multi-center study that we published this year in the American Journal, which unfortunately showed that this treatment did not help. If anything, there was a tendency for an increase in the risk of preterm birth. However, in a post hoc secondary analysis of the data, based on the first trimester cervical assessment, we found that in those with a short cervix, progesterone had a dramatic reduction in the rate of preterm birth, whether we define it as spontaneous births between 24 and 34 weeks, or between randomization at 12 and 34 weeks, or all preterm births before 34 weeks. There was a major improvement. Now, we are now in the process of thinking and planning whether we should undertake a major new multi-center randomized study to screen for cervical assessment at 12 weeks, and then the subgroup with a short cervix to treat with progesterone. Finally, I want to talk a bit about twin pregnancies, where again, from the very early days in the 1990s, with the introduction of the nuchal scan, we recognized Sepulveda that we can distinguish between monochorionic and dichorionic twins based on this lambda and sign, and that in monochorionic twins, the risk of miscarriage and perinatal death was much, much higher than in dichorionic twins. And the major study that we have undertaken and published recently on more than 6,000 twins, again, showing that the survival rate from entry at 12 weeks, the rate of loss was much higher in monochorionic twins and much more so in monoamniotic twins. And also that in monochorionic diamniotic twins, the risk of miscarriage, the risk of need for laser because of twin transfusion syndrome was very much dependent on the discordance in crown rump length and nuchal translucency between the two babies. I will be finishing on the issue of gestational diabetes and obesity. We developed models from the first trimester based on the history that are performing relatively well, but unfortunately, we have examined many, maybe 100 different biomarkers for the first trimester to see whether we could improve the prediction, and we did not find that to be useful. Obesity is obvious from the first trimester, and the risks of all pregnancy complications, miscarriage, stillbirth, preeclampsia, diabetes, large, for gestational age and cesarean section are substantially increased the higher the maternal body mass index is. It is absolutely impossible to intervene in a useful way by asking these women to go on diet or to go to the gym. It is far too late. The only question that we had was whether we could intervene early in pregnancy by giving the women metformin to stop them from eating so that they would have a less weight gain. And indeed, we found a significant reduction in the weight gain in those that were receiving metformin, and a substantial reduction in preeclampsia, but unfortunately not a change in the incidence of gestational diabetes. I will stop. I have spent my 1 hour discussing the concept and the clinical implementation of the inverted pyramid of care. Thank you very much.
Thank you, Professor. Excellent talk. Fantastic. Too many things. I will just stop this sharing just to have a look. Everyone.
Sorry, Mauro, I'm sorry, I couldn't hear. Yeah.
Okay. Now you can hear me?
Yes.
Yeah, perfect. I said that excellent talk. Thanks very much for all this information, because it's so valuable for us to know your feeling, your philosophy, which is, I think, the most important thing here. Because as you said, this is sort of evolving things that is changing. Numbers are changing every year, and some people are became stressed because of that, because the numbers change. But I think the main thing is the thing that you said, which is the philosophy, the idea, the concept behind this. So I think for that, I feel very grateful to have this talk today, and to just share with the rest of the community here, Chilean and Latin American community, these concepts. Just I would like to ask you, before leaving the word for other people here, for other friends here that are here, and I would like to ask you because there is some sort of research, because I would like to know your feeling about this kind of research, about the prediction of stillbirth, term stillbirth after 37, 38 weeks. And there is a ratio, which is the middle cerebral artery and umbilical artery ratio, which is sort of a researching, no? You have published something about that? You don't believe a lot about these things about this ratio? But the group of, for example, Barcelona is still sort of running a research about that to try to find out if this ratio is useful to predict stillbirth. How are you feeling about this? I
am 100% sure that they will fail. We have published data on more than 50, 60,000 pregnancies, and we have confirmed what we knew in 1985 with Peter Sudhill, when he was my fellow. Now he was a famous professor, and now he's even retired. But at that time, we found that in babies that were small for gestational age, those that were asphyxiated, because at that time we were doing choreocentesis in very small for gestational age babies, we were checking the karyotype, and we were checking blood gases. And we found that in small for gestational age babies that were hypoxic, the umbilical artery pulsability index was increased, and the middle cerebral artery pulsability index was decreased. So Of course, the cerebroplacental ratio has been reinvented, because quite often this is what happens. People forget what others have done 30 years before, and they reinvent things, and they get very excited about something very new because they don't know history. They don't like to think of history. At that time, with Peter Soothill, we found that in the subgroup of babies that were very, very, very small, those that were hypoxemic, they indeed had a redistribution in the fetal circulation. And we wrote in an article in the BMJ, it would be great if the same ratio was also true in not small for gestational age babies, because then we could abandon the idea of screening for size and replace that with screening by Doppler. We had carried out such studies, however, in the 1980s, and we found that unfortunately, in non-small for gestational age babies, this relationship did not hold. More recently, I think that in something like 30,000 pregnancies at 32 weeks and a similar number of cases at 36 weeks, we have looked at the cerebroplacental ratio as a predictor of various adverse events, fetal distress in labor and cesarean section, low APGAR score, neonatal unit admission, and published that last year in the American Journal, where we found that unfortunately the cerebroplacental ratio is not sensitive. You know, when you have 30,000 dots, if you have 1,000 dots, you can create significant associations with a value of R of 0.03, a ridiculous association. When you look at the line, it's so very flat, and there's such a wide scatter of results around it. Yes, you have found a significant association, but it is clinically quite insignificant. So unfortunately, I think it is good, because I have enormous respect for Figueras, and I think it is good to do the studies. I don't know, maybe you are also included in that, but I can tell you now the results. You will fail.
Yes, I think that's going to be the results. But as you said, it's always very useful to try to visit the previous publications, and I think I will see, because I'm sort of collaborating with him as well, so I will see what's going on the result. But a part of that is a research that have some ideas about the prediction of stillbirth. Do you think that there is another tool to predict that stillbirth at term? Because this is a sort of massive, not massive, but it's sort of dramatic things that happen to pregnant women.
Yeah, I think that the 36-week scan in England, for example, we don't have a third trimester scan, and we have to use the symphysis fundal height with the measuring tape of Cardozi. I mean, we are so very primitive. As I mentioned before, the 32-week scan is useless in the prediction of smallness at term. And the best thing that you can do is bring the scan closer to term. So a 36-week scan will identify babies that are small, that you missed before. They will identify pregnancies with oligohydramnios. And then in that subgroup, you will find the Doppler indices of the middle cerebral artery and the umbilical artery that would help you, given a small baby, whether you deliver them at 37 weeks or 38 or 39, or let them be, in the management of the very, very, very small baby. The concept that in the non-small baby, the cerebroplacental ratio will be altered and they're about to die, I think it's a delusion. The only thing that will do is produce a lot of unnecessary cesarean sections, because you're pressing too much or not enough on the head. And if you repeat the middle cerebral artery Doppler a few minutes later, the values will be different. Because actually, at that gestation, the ratio is not driven by the umbilical artery. The ratio is driven by the pressure with which you do a scan of the brain. But you tell me your experience, Mauro.
Yeah, yes, of course. It's very. I think I agree with you that you can find that the middle cerebral artery PI change within a minute. So I think you need to. I think the most important thing is the thing that you said, that it's important to try to see how the baby is. It's small. I think it's quite important. But apart of that, I think if the mother has some pathology like hypertension or diabetes, for example, maybe it would be fine for those groups. Yeah. But I think it's for the healthy baby, yeah. Healthy mother, it's going to be quite useless, I think.
And just to summarize again for your audience, if we look at stillbirth, let's again go to the arbitrary cutoff of around 32 weeks. About 75% of them will be in small for gestational age babies or pregnancies with preeclampsia. If we go at 32 to 36 weeks, it's going to be about 50%. And if you go to 37 weeks and beyond, it's only 25%. So only 25% of the stillbirths at term are in babies that are small or they're associated with preeclampsia. I have also looked, and we published again in many, many, many thousands of women, because people also got very, very excited about the fleet and the PLGF and all of these things, that it will be a great markers of stillbirth. Yes, they are useful in the subgroup of the small babies that are showing signs of severe placental insufficiency. The idea, however attractive it is, that the baby that was meant to be on the 80th centile, that has now dropped to the 50th centile, and that is severe pre-terminal IUGR, it's a delusion. It's a delusion. They don't have abnormal Dopplers and they don't have abnormal biochemistry. So unfortunately, yeah, is what you said really. Is there coexisting preeclampsia? Because in these cases of preeclampsia, the babies are not small at term, unlike preeclampsia at early gestations. Is there diabetes? And often, is there mismanagement in labor?
Edgar, you want to ask a question, please?
Thank you. Can you hear me?
Yes.
Yes.
Okay. So first, I would like to thank Mauro for putting together this session on Sunday. Thank you, Mauro. And also to thank Professor. It's always an honor and a privilege to listen to you, Prof, and all the friends that they are also connected to this presentation. And I would like also to take the opportunity to, even that is not the subject, I will thank Professor for the beautiful documentary in Netflix. We have seen all of us, Professor, and everybody says that it's a beautiful, beautiful TV program, TV show. But for us that we lived experience in the old Harris has a very special meaning. Seeing all these endless lines of patients. So thank you for that, Professor. It's always a privilege. So my question is about the impact that we are having in the different conditions that we are looking at. I mean, if we look, for example, for preterm delivery, screening at 18 to 22 weeks and having progesterone, you have one of the first papers, the impact that we have is really low. We haven't changed anything in preterm delivery. And the same concept that you say that suddenly before 18 weeks of gestation and after 24 weeks of gestation, progesterone, it doesn't work. Yeah. It's a magic thing that it happens in that week. It's also applicable to this condition. The next point is, yes, in congenital anomalies, yes, in chromosomal defects, we have made a lot of new things. We are doing better things early pregnancy, but for preeclampsia, now that we have this, but for late preeclampsia, for diabetes, for obesity, for inflammation, for preterm delivery, we actually have been not very successful and limited. My second point, Professor, is in this concept of inversion of the pyramid of care. It seems that we have to put all the resources in the first trimester, but maybe, and that's an opinion, we have to improve the assessment at each gestational week that we do the prenatal care. Instead of just focusing in one first trimester, each time that the patient is coming with us, we have to refine our methods to make a better diagnosis and to select cases that they probably will develop the complications at that time. So instead of just focusing in one period of pregnancy, the different times that we will see the patient, we have to improve the concept of how to make a better diagnosis and to prevent complications in that period of pregnancy.
Thank you very much. And I agree with you. Quite often in my life and in my career, I have been provocative because I wanted to emphasize something. And in a challenge to the previous pyramid of care, where you don't really care very much about the beginning and you focus on examining people a lot at the end, I said, come on, what you must do is do exactly the opposite. Place a lot of emphasis in the beginning. But of course, that's one, placing the emphasis in the beginning. But the more important thing, Edgar, was the concept of converting everything into a mathematical formula. And a lot of the models that we have, the competing risks models, are continuous models. I think it is critical that we assess, every time we assess people, for me, every assessment creates a likelihood ratio with which you modify the prior risk. I mean, that you must do things properly. Of course, you must do things properly. And my pyramid is not like the Egyptian pyramid that is made of stone. It's a very flax pyramid. It would be very wrong to advocate, forget about everything else and do everything in the first semester. You're absolutely right. We must examine people properly. You're absolutely right also about the lack of outcome impact over the decades. If we take preeclampsia, for example, and we look at this 30-year struggle to develop a first semester model and then a prevention, and then get anybody to look at the mathematics, they are quite depressing. You are predicting 75% of preterm preeclampsia. In most healthcare systems, the rate of preterm preeclampsia is about 0.5, 0.6, 0.7%. Let's call it 0.6. It's 6 in 1,000. And then if you identify this very effectively by first trimester screening, it is 75%. What a disaster. So you have 6 and you picked up the 4. And then you give them aspirin, 150 milligrams, and you say, fantastic. We now reduce the risk by 62%. So we reduce the risk of the 4 by 62%. So we made them now 2. So we have a condition that is rare, 6 in 1,000. We have undertaken all of this effort, and maybe we prevented 2 if we were really, really lucky and we manipulate the mathematics, maybe 3 out of 1,000. In the meantime, in that same population, the incidence of overall preeclampsia is about 2.5 to 3%. So, and we did not touch any of the remaining 14 to 16 cases that are the term preeclampsia. In terms of preterm delivery, yes, if we go and screen on the basis of previous history, my God, this woman had a previous preterm birth, let's put all of our resources into this group. We didn't achieve anything very much because only 15% of the preterm deliveries in this pregnancy will arise from women that had a previous preterm birth. So actually, before we start, we missed 85%. If we do cervical assessment on everybody, and there's not a single country that advocates that, I advocate it, in my clinic we do that, but there's no single country that advocates that, then we will increase the detection rate from 15 to about 30%. So we still missed 70. And now if we blast the women with a short cervix by vaginal progesterone, we will have reduced the risk by about 40%. So again, we are reducing the risk of 40% of the 30% that we identified. So we will always have a very small impact. That is a fact, and it is unrealistic for us to believe that there is a simple solution for these problems. It's a continuous struggle. But I say, on the other hand, to pick up, to reduce by 60% the 0.6% that could lead to maternal death, to me, is worthwhile. It is better than nothing. And the same, really, in screening for preterm birth. If we reduce a bit the rate, it is better than nothing. But the battle will remain for decades, new generations of people to come. Yeah.
Thanks. Álvaro Sepúlveda, who is a member of our unit and organizer of this meeting as well, want to ask you a question, Prof.
Can you hear me?
Yep.
Yeah. Okay. Well, first of all, I would like to thank Professor for this brilliant talk. It's always good to listen again. I think this is the third or fourth time that I listen to this speech, and it's always with new evidence that give us a new perspective of what is in the world of fetal medicine. So thank you again to arrange your time to be here. So I have two questions. First is about the moms, because when you applied the computer risk model in different populations, I think that is your opinion is that we need to use a single model for universally for all the population. But do you consider that it's better to adjust the moms, for example, for the UTNRT Doppler and the mean arterial pressure locally, using your model? And the second is regarding your publication about the secondary analysis of the aspirin in the population with chronic hypertension, that you demonstrate that there's a non-significant increased risk of preeclampsia in those that have a chronic hypertension. So when you read that paper, maybe some people can confuse us about, should I use aspirin in women with chronic hypertension or not? Because even that the risk is higher, if you say that maybe there's an increased risk of preeclampsia, maybe we should not give them to this population aspirin. So what is your opinion about that?
Thank you very much, Alvaro. Very good questions, both of them. Let me deal with the first one. According to Bayes' theorem, which is the basis of all of our work, Bayesian statistics, when you try to calculate the risk, you take into account various maternal factors, and you define those maternal factors by a multiple regression analysis. When you then want to act, and that gives you the prior risk, yeah, is the same. My maternal age is, I don't know, 35, so my starting risk for Downs is 1 in 300. Then when you take a biomarker, and let us call that PAB-A, this measurement that comes out of the machine depends on the machine. You can have the Cryptor, you can have the LIPS, different companies, unfortunately, when they produce a measurement of PLGF, the values are quite different from each other. They have not managed to unify their measurements. So a value of 5 from one machine is different than a value of 5 from another machine. Then the value of 5 that comes out of the machine depends on what I call the bucket. And the bucket is the woman, and the woman is the size. A woman that has a bigger size, a product that comes from the placenta will be diluted into a bigger bucket of water. So the value will go down. Then it depends, we find, on the race. If you are black, for the same value, it means different things than if you are white. Then we find that it depends on the method of conception, on whether you smoke, and so on. Many of these factors are also in the prior model. And it is a basic principle of Bayes' theorem that when you measure a biomarker, you must adjust the values for the same factors that are in the prior risk. Otherwise, you are counting a factor twice. For example, Black women have 3 times a higher risk than white women of getting preeclampsia. And in Black women, the values of PLGF are different than in white women. And therefore, you need to correct the value of PLGF for Blackness, and so on. So this is the ideology of, it's a basic principle of Bayes' theorem that you need to adjust those factors. In biochemistry, we somehow have accepted that, and you adjust the PLGF. What we have been very resistant to do is do exactly the same in biophysical markers. Because of course, the same is true for the measurement of mean arterial pressure and uterine artery pulsatility index. And when people tell me, is the UTPI, what is the cutoff? And then I remember when I was many, many decades ago, when I was extremely angry when people were talking about notches. And I said, what is a notch? Is my nose big or small? It depends on with which race I compare it with. What is a notch? Is it the deep notch? Is it a shallow notch? Is it the double notch? I was allergic to those things. Like I'm allergic to cystic hygroma. I don't know what is cystic hygroma. I know that the nuchal of 7 is very bad, but I don't know what is cystic hygroma. So that was the issue of the measurement. But in England, if the uterine artery PI at the 20-week scan is more than 1.6, that is very high, and you need to see these women. But 1.6 on which day? At 19 weeks, or 20 weeks, or 21 weeks, or 22 weeks? The 95th centile is completely different. It's not flat at 1.6. And then 1.5, 1.4 for a Black woman, a smoker that conceived by IVF and is obese is completely different in its significance than a different type of a woman. So I'm sorry, but I'm taking a long time to answer your question. The logic is that if you are going to combine the prior risk with the biomarkers to produce a posterior risk, you need to adjust the biomarkers, biochemical and biophysical, for all of these things. But your question was not that. Your question was more fundamental. Is a uterine artery, a PLGF, a mean arterial pressure in Santiago different than it is in London? Of course it is different, because I don't know what is London. I went to have coffee this morning because I'm having chemotherapy and I'm not allowed to have anybody come to my house, so I have to go outside to see people from a distance. And I was looking at the people and said, who are the English here? There was not a single English person. They all looked strange. They looked Black, they looked Chinese, they looked Cypriot. I said, so what is English? Since there are racial differences within my population, what is a given value varies on your own racial background. So I expect the values to be completely to be different in Chile than they are in England, and I expect the values to be different in London than in Liverpool, and I expect the values to be different in my hospital than in the hospital on the north of London, where they don't have enough Blacks, but they have a lot of Jews. So yes, you need to adjust your values depending on the population that you're examining. Now, in biochemical screening, for the last 20 years, because it was alpha-fetoprotein and then PABA, each hospital, each laboratory, each month adjusts their MOMs. And in England, and maybe it is one of the very few countries in the world, the government is identified my hero, and my hero is called David Wright. He is the one that does all of my mathematics, and most of the time I don't understand what he's doing. Eventually I do. David Wright sits at home and every 3 months receives from every hospital in England the results of their biochemical values and the results of their nuchal translucency every 3 months. And then he feeds back to them how they need to adjust their values to make them relevant. And they look at the distribution of the nuchal translucency, and they send these traffic lights, yellow, red, I don't know, green, whether you can continue or they need to stop and to be reevaluated. So it has taken me a long time to answer your question. Not only it is useful, not only it is important, it is critically important that in each center, you almost adjust your values as you go along. The second question was about chronic hypertension. We must always be very careful about secondary analysis in trials. You know, a trial is constructed for the primary analysis, and the secondary analysis is almost to create a hypothesis. But it was incredible. When we looked at all of the maternal characteristics and the effect of aspirin, more or less it was consistent. But in chronic hypertension, there was no impact at all. If anything, there was a tendency for it to be increased. The numbers were small. So Alvaro, with that reservation in mind, so I cannot be too dogmatic that chronic hypertension, no, it's dangerous to give it. I think we have to approach chronic hypertension in a completely different way. I am sure that you grew up in the same way that I grew up, although I grew up a lot of time before you grew up. And our teachers told us, be careful with chronic hypertension. You must not lower the blood pressure too much, because God made the system that if you have chronic hypertension, it is good to keep the blood pressure up so that the perfusion to the placenta is better. And if you lower the blood pressure, it's a disaster. The babies will die, the babies will not grow. This is what my teachers told me. Did your teachers tell you the same thing? Yeah, the teachers are always the same. They read the same book and they copy from each other and they create the dogma of medicine. Now, so the dogma was that if you see a woman with chronic hypertension, you tolerate a blood pressure of 150 over 100, and you don't begin to treat them unless the blood pressure is above that, because you will reduce the perfusion and the baby will have psychological problems and it will die and it will not grow. That is how we were brought up. Now, in adult medicine, they almost have the same thing. Don't treat people with chronic hypertension unless their blood pressure is very high. And then people started looking at the blood pressure almost in the same way as in the Hippie study in diabetes. And they say, but why are you so stupid in medicine? We create these arbitrary cutoffs. Gestation of 32 weeks, gestation, as Edgar was saying, bang, 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 arbitrary cutoffs, blood pressure 140 over 90 or 150 over 100. And they looked and they said everything in life and biological system has a continuum. And they found that the risk of death, cardiovascular disease, in people with chronic hypertension was linearly related to the blood pressure control. And now I have now hypertension, and the advice is that I must keep my blood pressure not 150 over 100, not 140 over 90, not 130 over 80, to keep my blood pressure 120 over 75. That is what the cardiologists are telling people. And I think that we need to revisit this ideology in obstetrics and chronic hypertension. And the studies that I want to see is aggressive control of blood pressure in chronic hypertensives from the first trimester. So I don't care very much about the aspirin story, whether it is dangerous or not, or whether it works or not work. What I expect, what I want to see is aggressive control of blood pressure from the beginning, whether that would have an impact or not. That's, I have taken a long time to answer your question, Barbara.
Thank you very much. It's very clarifying.
Thank you, Prof. I would like to add some about exactly the same thing about hypertension, because as you said at the beginning of your lecture, that there is two ways to calculate the risk of a woman to have a preeclampsia. One way is to use the history, the NICE or the American College of Obstetrics and Gynecology. The other way is to use your algorithm, the Fetal Medicine Foundation algorithm, that includes all the things that you have mentioned. And there is always a problem with that, because normally, for example, a specialist, medical specialist, like a rheumatologist, always ask or sort of say to the woman that they need to use aspirin because they have lupus. And then the women go to the scan, the ultrasound scan at 11 to 14 weeks, and we found out that the woman is not at the risk of having preeclampsia. So we have these two things. The rheumatologist said you need to use aspirin, and the algorithm doesn't say that. What would be the answer of that terrible question?
Kill the rheumatologists. Mauro, I have exactly the same problem, of course. When we were doing the aspirin trial, I was constantly frustrated by women that were arriving and they were put in by their general practitioners on aspirin because they have diabetes, because they are obese, because they have chronic hypertension, because they had a previous pregnancy with preeclampsia. I mean, it is the propaganda of medicine imposed this way of thinking across. And it takes a long time to re-educate the whole medical profession really about this new ideology of calculating the individual patient's risk and deciding on what to do. It has taken many decades in the United States by the official bodies to say we don't need to do an amniocentesis on somebody because they're over the age of 35. In many, many countries, in Greece, in Italy, in Turkey, in many, many countries, and I suspect many countries in Latin America, it doesn't really matter what has happened in the last 40 years in terms of first trimester screening. Still, if you're over the age of 35, you are impulsively told you're at high risk and you're directed towards having an amniocentesis. So don't be surprised that somebody that is on chronic hypertension already is being advised by somebody, a physician, before to be taking these medications. It will take time.
Yeah.
Frustrating, but it will take time.
Yeah. Alvaro, I don't know if you have some question from the YouTube chat, but would be fine just to leave the chance to those people to ask a question. And I don't know, Prof, you have enough time to spend another 10 or 15 minutes? That's fine for you?
Yes, of course, with pleasure, yeah.
Okay, thanks.
Okay, so there's, I think, like 5 questions. First, well, thank you very much for your presentation. When you don't have the chance to ask for the biochemical markers, do you recommend to use the inverted pyramid of care, even without the biochemical markers?
Yeah, listen, again, so you can calculate the risk of somebody based on the history. And the history can be what we learned at medical school, 1, 2, 3, 4, 5, or the NICE guidelines or the American College guidelines. These are the high risk factors. We then said, this is silly because they said, if the body mass index is above this, and if the age is above this, they say, but what about if it is 1 day before your birthday, or you are 1 gram less than the kilograms that you are classified as being high risk? And they say, let us use a mathematical model to put all of this information together, because quite often, many of the risk factors are interrelated. If you're a Black woman, you are more likely to be overweight. You are more likely to have chronic hypertension. You are more likely that your mother also had preeclampsia when she's pregnant. And if you had a previous pregnancy, you are more likely to have had preeclampsia as well. You cannot treat each one of those factors as being independent of each other. So the best thing to do is do a multiple regression model and put them all together. And using that model, you calculate the risk. Now, if you are good in, if you have a sphygmomanometer, which is about $50, and you measure the blood pressure, and you measure it properly, and we call it mean arterial pressure, and you add the mean arterial pressure, the accuracy of your risk is more than if you don't add the mean arterial pressure. If you are good in ultrasound and you can also measure the uterine artery pulsability index, and you do that, again, it is better than if you don't. If you have money to measure PLGF, you are improving your detection rate by about 5%. So what I said before, a preterm preeclampsia of 75% detection rate, if you take PLGF off, you are down to 70%. It's better than the 40% of the NICE guidelines in the American College. Yes, but 70 is a lot better than 40, but 70 is less good than 75. So yes, you don't need to do biochemistry to calculate the risk. Put whatever you can afford within it. In my hospital, my hospital does not give me money to measure PLGF. And it doesn't matter that I publish that PLGF is necessary. It doesn't matter that I say that PLGF is better than PABA. I have to rely on PABA because I don't have money to measure PLGF. Sorry, again, I have taken a long time to answer.
No, thank you. Thank you for your answer. There's another question regarding metformin. Based on your presentation, in which group do you recommend to use metformin?
So in our study, we took hyper-obese women. And that is a group that received the metformin. That was a negative trial again. The primary outcome in that trial was the birth weight. We wanted to reduce the birth weight, and we failed. But a secondary outcome was preeclampsia, and that is where we found that was a reduction. Now, the question to me then is, why am I giving the metformin? It's not a very pleasant drug, metformin, by the way. I mean, you need to take a lot of tablets, and they have side effects. What am I giving the metformin for? To reduce birth weight? I will fail. To reduce gestational diabetes? We failed. To reduce preeclampsia? Yes, it was one study, but actually we achieved the same things by giving aspirin. So I wouldn't advocate metformin for a certain cutoff in maternal weight as a method of preventing preeclampsia.
Okay, thank you. And the last question from the YouTube is regarding your algorithm for the FMF algorithm for SGA that is published in the website. There's some critics about the incorporation also of the biophysical profile in the management. So okay. What's your opinion about that?
I'm afraid I will talk a lot again. What is SGA? Now, we have the WHO graphs, we have the Intergrowth 21 graphs. We produced our own graphs, and we all made one simple and stupid mistake. Let me tell you what is the mistake. We take women that are delivered at 30 weeks, and we use data from women that deliver between 20 weeks and 37 weeks, and we say we will construct a normal range based on these birth weights. Yeah? But we don't stop to ask, but why did a woman deliver at 26 weeks? That, by definition, is a pathological pregnancy. It's like going to a village in Chile where everybody has hypothyroidism and constructing normal ranges of thyroid function from the village where everybody has hypothyroidism. If we accept this reality that a lot of the preterm births, for one reason or another, are pathological pregnancies, how can we be so stupid to use pathological pregnancies to construct normal ranges? That is one. And I made the same mistake. We have graphs. It's called a publication by Leona Poon, with me as the last author. We have our own normal ranges again, based on birth weights. And then I kept, it's important to tell you the story. I had an irritating banker, Greek banker. Can you imagine? There can be nothing worse. That I was doing scans on his wife. And I was telling him that the baby was small because I was plotting it on the estimated fetal weight. And the baby was small. And I was giving him the birth weight, the estimated weight. And this guy was coming next week and he told me, but I checked and my baby is not small. My baby is on the 40th percentile. But I said, what are you talking about? Well, he said, this is the graph. So he was showing me birth weight charts, and on the birth weight charts, the baby was on the 40th percentile, and on my charts, the estimated fetal weight charts, it was on the 3rd percentile. They said there's something very seriously wrong here. And I looked for the first time, I was so stupid, for the first time, I looked at the birth weight charts and the estimated fetal weight charts, and they were similar at term, but they were very different for preterm. The birth weight charts were much, much lower than the estimated fetal weight charts. Only last night, I submitted another paper on growth restriction, and I was able to look at the estimated fetal weight, the 10th centile, yes, of the estimated fetal weight, is well below, the 10th centile of the intergrowth 21 is well below the 1st centile of the estimated fetal weight. Yeah, it's well below that. So the first thing that we must do is reconstruct birth weights without taking into account the babies that are born prematurely. But what am I talking about? This is crazy. There's a great man that I admire that was the president of his work, and he is in Sweden and he's now retired, Marsal. In Sweden, they use the estimated fetal weight, yes, as birth weight charts. So I asked David Wright, because if you take 100 babies and you do your estimated fetal weight today, and then these babies are born tomorrow, there are a few mistakes, but overall, there is quite a good correlation between estimated fetal weight and birth weight if the birth occurs very soon after the estimated fetal weight. But why should the estimated fetal weight charts be so different from the birth weight? It's because a lot of the premature babies arise from pathological pregnancies, and it is very stupid to use pathological pregnancies to create normal ranges. So David Wright, therefore, produced the Fetal Medicine Foundation charts, where I am the first author, Fetal Medicine Foundation estimated fetal weight and birth weight charts, where they're similar to the intergrowth in the WHO at term, but they are much, much higher before term, because that's how the estimated fetal weight is. So the first thing to talk about is that when we are comparing an outcome called the small baby, which charts are you using for the definition of a small baby? And I believe that the ideology of our chart is more compatible with the logic than the other charts. The second thing is what we said before, really, which gestation, what deviation from normality, how many Z scores below the median are you? And this is what these Papastefano charts are being constructed now. And we will hopefully have them on the website in a couple of months, where again, if you have the first trimester, you can just take the history alone, or you can use history and uterine and PLGF. If you go to the second trimester, you can use the history and the estimated fetal weight, the biometry. And again, you can add PLGF if you have money, or you can add the uterine. So it depends on how many things you want to add by biomarkers. Yeah, 3 months.
Professor.
Yeah.
Thanks, Professor. Just I would like to have the last question, because I know that it's almost just 2 hours here, but it's absolutely fine. No? For me, it's fine. I don't know you.
I used to smoke 80 Marlboro a day, so that by now I would be dying for 10 cigarettes.
Yes.
But
so I will just
on the 7th of November last year, they told me that because I'm going to have chemotherapy, if I don't stop smoking, I will die. I stopped that day, and although I was convinced that I was a drug addict, I never wanted to smoke again. So I have more time.
And the question is going to be by one of the friends and colleagues here, who is Juan Pedro Kusanovich, who used to work with Roberto Romero. He's a very close friend and researcher of Roberto Romero, and he wanted to ask something. Please, Juan Pedro, you are here? Because you sent me a question by...
Hi, morning to everyone. Hi, Professor. So good to see you in such a good shape, and
I'm also working with Roberto Romero a lot. Yes.
I know how much he appreciates you and how much he loves you. So we are happy to see you in a very good shape, and we wish you the best.
Thank you.
And of course, we are so happy that you are so provocative and so, your philosophy, is amazing. So
you know why? You know why? Because I always challenge myself.
Yes, I agree.
I always have uncertainties. I don't know. I find something and I'm not sure. I say, we need to find out more. We need to investigate more.
Yes.
And so it's because I am not dogmatic. And I'm always searching for more answers. But anyway, please continue.
No, but you're true. You're right. This is we are like sheep, following each other and not challenging anything. And we need to challenge everything. Yeah. And just it's a very simple question. Is that we have explored the use of the PLGF, soluble fleet, and also soluble endoglin. And most of the time, people are using soluble fleet and the ratio of soluble fleet and PLGF. But my question is, what about the ratio between PLGF and soluble endoglin? Because it seems that it has a very good performance for the diagnosis or prediction of preeclampsia. And I don't know what is your opinion about that?
Juan, the problem is we have research tools and you have tools that have a clinical applicability. And unfortunately, endoglin has not been produced by the companies to be freely available. That's the problem.
That's it.
Yeah, that's all. Okay. Because I can pick up the phone now and I can ask Yvonne Parker of PerkinElmer, and I tell her, Yvonne, I'm going to do this third trimester study. Can you please help me, or can you sell me reagents for the biomarkers? She said, yes. Now PerkinElmer has its own fleet. So we'll have a PLGF and fleet. There's no chance of having an endoglin.
Okay.
That's the first point. But I want to make another point for you, Juan. David Wright, my hero mathematician, is very much against ratios.
Okay.
He doesn't like BMI. He doesn't like fleet to PLGF ratio. He said, but why are you so stupid? He said, why don't you take PLGF and fleet or endoglin or anything, weight and height separately, and see how, because their relationship may be changing. Why do you need to be forced to accept a ratio of 1:1? It implies that they're equally important, and maybe one is more important, or at 36 weeks, the one is more important than the other. Why don't you put it in the regression model independently? You are endocrine, don't use ratios, but this is a different point. But unfortunately, I have seen the publications, and I know that you have done with Roberto on endocrine, but we just don't have the assay.
Okay,
it's
that's fine.
I don't know, do you know why the companies are not
No.
to?
No. I don't know. I don't have any idea, and I saw that you maybe have any more knowledge about that, but no, I don't have any idea about that. I'm sorry. And can I ask you one more thing, if you have the time? So it's about preterm labor, and the cervical length change during gestation, and we are using the same cutoff, probably like less than 25 millimeters, or less than 20, or less than 15, all the time. And I mean, more or less 1% of the patients have a short cervix between 20 to 24 weeks, if we are lucky. But we find several patients maybe that have a really short cervix between 24 and 32 weeks. Yeah. And at the end, those are the ones that also are having a preterm delivery. So what do you think about maybe, customizing the cervical length per week, and also, of course, depending on the population and depending if it's a singleton pregnancy or a twin pregnancy?
So very good again. Ideally, what you need to do is create moms.
Yeah.
Again, now, and in the moms, you will be taking into account gestational age, and you will be taking into account other maternal characteristics. It cannot be that we are using the same cutoff for all races, all sizes. I am 100% certain that we are doing that for mean arterial pressure. We are doing that for uterine artery Doppler. I am sure that eventually we should be doing it for cervical length. But let me tell you something that I feel very guilty about in terms of the cervical length. I did not show the same obsession that I had with nuchal translucency. So I bet you anything you want that in this panel, and I recognize many extremely good people, the measurement of cervical length will vary between you. So we have not really somehow created a military structure to define exactly how people are measuring cervical length and monitoring that measurement.
Yes.
So number one, we need to work harder at defining the specific criteria and creating a method of audit for the measurement of cervical length. 150% that must be adjusted for gestational age, 150%. But the question that I'm raising is whether it should also be adjusted for maternal characteristics.
Yeah, for sure. Yeah.
So it's up to you.
Absolutely, yes. It will be done for sure. Thank you, Professor, and please keep it strong. Okay.
Thank you very much indeed.
We need you a lot.
Thank you.
Professor, now I promise you that it would be going to be the last question, because Ricardo Palma Diaz, you know him. He used to be with us at King's College.
He's Australian now. He must be.
Now he's Australian. He's a Brazilian, but he's Australian.
I know.
Now he wanted to ask you the last question, please.
Yes.
My question is progesterone in twins. You mentioned the limitations of a secondary analysis. So we have a positive result coming from a secondary analysis. So what do you expect to see in a prospective trial of progesterone for cervix below 30 millimeters in twins? Are we going to see a dilution of that effect? Is that going to hold true? What do you expect?
Ricardo, you're absolutely right. And that is why I defined earlier this issue of secondary analysis arising from a trial. Our primary aim there was to see whether universal treatment with a high dose of progesterone, 600 milligrams in all twins, would be effective. And we found that not only it was not effective, but if anything, there was a tendency for an increase in preterm birth. And then David Wright spent a lot of time looking at different subgroups. We had included in the primary analysis, in the statistical analysis plan, that we would be adjusting for cervical length. And then that is how this subgroup with a cervix of less than 30 millimeters, which was 13% of the population, we found this dramatic effect. So like how we should always view the results of secondary analysis, it should be viewed as a hypothesis generation. And that is why, however traumatic it would be for me, because you would need to screen about 4,000, maybe more, twin pregnancies. And that will take us twice as long as it took us to do the events study, unfortunately. We need to do a study, and we are working on that to see whether we can do a major multi-center study, screen, measure the cervical length at 12 weeks, and then randomize that group into 600 milligrams of progesterone versus placebo. Until that, we cannot really say that that's what we should be doing. Yeah, you're right.
Perfect.
What time is it? What time is it in Australia, Ricardo?
3 in the morning. Yeah?
It is 3 in the morning now. Yeah.
3 in the morning. Oof. Fantastic. Thanks, Ricardo, for being here as well. And the professor, as I promised you, just the last question, just to leave you to have your cigarette or whatever thing that you like to do now, or coffee. I know that you like a lot. But now I see that you have a t-shirt with the Adidas t-shirt. Maybe you are running now, no?
I'm not running yet, but I'm walking.
Ah, yeah, perfect.
For 50 years, I never walked. And now every day I have to walk, mainly to escape from this house, because I'm going to go crazy if I stay here any longer. Yes.
Yeah. Yes, I want to end this webinar on maternal fetal medicine by thanking Professor Kypros Nicolaides, my teacher and my mentor as well as many of my friends and colleagues here present for the constant generosity, which is very important for me, and towards me, of course, and my unit that I lead now in Chile, but very especially for allowing a more equal access to scientific knowledge and thought, and through it, to this equal access to scientific knowledge, improving the health of pregnant women in our Latin American countries and around the world. So because of that, Prof, thanks very much for being with us and allowing us to enjoy with you excellent talk and all your knowledges and your concept and philosophy. So thanks a lot for that. I don't know if you want to say sort of last word for the community here that is present in the Zoom and the YouTube as well.
I want to tell you how much I love people from Latin America, how my unit has a lot of people, and how much I have benefited over the years from having people from there. Our people are very similar. I come from Cyprus, and my people are very similar to the people of Latin America. I grew up in the 70s as a student, and I was suffering the pain of many of the countries in Latin America that had dictatorships at the time. And I am very grateful to the many research fellows that have worked with me, you, Mauro, Ricardo now, and so many others that have contributed to this accumulation of knowledge. For as long as I'm around, I will continue to be close to you and gain from your experiences and share with you mine. So I wish you a happy Christmas and a healthy new year for everybody.
Thanks. Thank you, Professor. Happy New Year for all as well, and a Merry Christmas. Thank you very much.